صباح الخير, good morning. Hala? I'm putting Hala on the spot and Jana as well. Hala sahla. Yara is over there. Okay, great, good morning. I mean, you can come to the table if you wish, but also you can feel wherever you are if you want to say. Good morning, my name is Nasser Yassin. I'm the head of research here in the Institute, and I also teach health policy in the Faculty of Health Sciences. Thanks for coming. I think this is a great group in this summer morning, and the idea I want to present the findings of a research we've done. Actually, we started doing a couple of years back, and then we did some update, and we've been working on it for some time, but we've been postponing its presentation since last spring. And this is a joint work that I've been done first with Ms. Jana Shamma. Jana was a researcher with us in the Institute, but she left to another job. And Yara Mrad, our manager for the refugee program, and Hala Alawi also a colleague and researcher. She's affiliated with us in the Institute, but also she's a public health graduate and expert in qualitative health research. Of course, with others, including Maisa, who's contributed a lot for the last couple of weeks. So this is a joint work, and the idea started with really trying to understand the informal adaptive mechanisms that refugee communities have or adapt or work through to protect themselves or to cope with the displacement crisis and the weight that is put on them. We actually started this track of research not only on health-related issues and seeking health care or hospital care, but also we're doing it in terms of access to livelihood, education, and other ways, trying to understand refugees' agency themselves, actually, how first, whether they're coping, we're able to cope, but also if they have agency and how they're proving this agency when it comes to different sectors, different services, and access to different aspects of their life. We also believe that refugees are taking most of the burden themselves, and that's our position on that. They take most of the burden. Of course, host communities are taking a lot of refugees, mostly the poor host communities in Lebanon, but also we think that refugees are taking most of the burden, and for that we need to understand how they cope. So just to give you a bit of background, probably you know, those who work in the field, at the moment we have close to 950 million registered Syrian refugees. Of course, for the last 3 years, around 70% of them have been below the poverty line. Around 51% of them are actually in extreme poverty. 87% of the refugees live among the poorest Lebanese. That's around 67% of the poorest Lebanese. We try to remind ourselves of these facts, on these realities, in order to understand some of the outcomes of this research and other research. In this study, we also looked at Palestinian refugees, not only Syrian refugees. We also looked into Palestinian refugees from Syria, as well as their host communities. And the objective of this research is to understand how Syrian refugees, Palestinian refugees, stateless Lebanese, Palestinian refugees from Syria, and their Lebanese host communities actually cope when it comes to access to hospital care. What do they do? And for this, we applied a qualitative research method where actually we actually checked people's real access to hospital care or need to hospital care, rather than asking what would they do, asking some kind of virtual question about the access to hospital care. So we went and we used, we knocked a lot of doors through some of the NGOs, through some of our local partners, and we asked for an experience of hospital care in the past 12 months of the study. And then we went through those communities or through those households to really get into the details of how they managed to access hospital care. And I'll show you through the study the details of this. And the idea of understanding the adaptive mechanisms, and as I mentioned, is that we actually have been looking in previous research, particularly among Palestinian refugee communities and those who live outside the camps in Lebanon, and this is a research we published a couple of years back, how they managed to build informal institutions when it comes to access to water, electricity, solid waste, and so on. And this is an extensive research we did among Palestinian communities in Lebanon, where we actually looked into the way the formal and formal institutions are in many times, trying to be complementary, particularly when it comes to access to water, electricity, and environmental services. But that's not the idea of the research. But as we believe that the refugees have built informal institutions, that some of these institutions do work and they create a way to adapt to the conditions they live in, whether they are formally discriminated against through certain services or not. But also we believe that some of these informal mechanisms tend to create some behavioral adaptations, particularly when it comes to hospital care, where the expenses might be so high for them that it becomes so catastrophic that they may actually adapt not to seek care altogether or abort care. And that's something we try to look into in this research. So the aims of the study is to actually look into the service-seeking encounters of those refugee and vulnerable Lebanese families as critical moments to understand their vulnerability, but also how they coped with such critical moments. And we want to study the formal as well as the informal ways where those communities try to, facilitate their access to hospital care, and how they manage to cope. How they manage to cope, whether through their own means, whether they're through more formalized institutions, or whether different ways. And the way we did it, we established this through, again, as I mentioned, we map step by step each of the parts of a journey for hospital care. And those were real journeys for hospital care that those families went through in the past 12 months. And we looked into two geographic areas to study after extensive desk review of the communities we wanted to select. So we looked into Barilias and Biqa, which is a very urban area, and it's a Lebanese, of course, town, but it has been hosting Palestinian refugees, but also Syrian refugees recently, as well as stateless Lebanese or stateless communities who live in Lebanon. And also we looked into an urban setting in Sabra Shatila, which is in Beirut or suburb of Beirut, where also we looked into Palestinian refugees who are living in Lebanon, Syrian refugees, Lebanese, and PRS. Both have camp and non-camp populations, so also we included in our research both populations who live in camps and live outside camps. Of course, the camps in Sabra Shatila are different from the camps we looked at in Barilias, but still we took this as a factor. So these were the criteria for selecting those communities. Of course, that was done through understanding the vulnerability map that's been done by the UN interagency coordination mechanism that's in Lebanon, where they map these all the vulnerable and socially excluded communities in Lebanon. And this is how we did. So we went through those households and we asked them whether they sought or they were seeking hospital care, and how actually they went through and whether it ended positively or not. So that was the main question. And if they said yes in the last 12 months, we started to ask the details about how actually they felt about the situation, where they went through first thing, and how the experience was, and then the duration of treatment, and then we asked about the discharge, how actually it ended. And we asked about whether they coped with this, whether they managed to, how the experience was in terms of paying for it and coping with the needs that hospitals put. But before doing that, we established what are the formal, usually, mechanisms for hospital care. And let me brief you. Perhaps you know these, but let me brief you about how usually those communities formally need or can be, can get access to hospital care. First, all Lebanese, whether For those who are not covered by the National Security Fund, they can apply to the Ministry of Public Health. And the Ministry of Public Health, for those who are not covered by any of the schemes in Lebanon, whether it's Social Security Fund or their employees in the civil service, like the co-op of employees, or whether they are in military or security services. For those, around 50% of the Lebanese who are not covered, they can apply for hospital, to cover their hospital care through the Ministry of Public Health. And the Ministry of Public Health has now a process to do so, where they cover 85% of the bill. Now, for those who are members of the National Poverty Targeting Program, those are the poorest who were identified by the Ministry of Social Affairs, they can get or apply for 100% of hospital care. So this is usually for the Lebanese, this is the formal way of accessing hospital care. Now, for Palestinian refugees who live in Lebanon and registered with UNRWA, the UNRWA, again, has, I think anyone from UNRWA can explain the details of this, but they are in agreement with the Palestinian Red Crescent hospitals, where they would cover the 95% of the bill, and 5% of the bill is covered by the patient themselves. For the government hospitals, they cover 85%, and if they go to private hospital, they cover 80%. These do change sometimes, and I think we need to listen after when we get the presentation done to colleagues from UNRWA. Now, for Syrian refugees who are registered with UNHCR, they cover 75% of the hospitalization bill when they go to a private hospital or to those who are contracted through the UNHCR system. And I think in some of these I think the system is changing at the moment, but also this is at the time of research, the coverage was 75% of the bill. Although, as we saw in this research and other research, 90% of respondents reporting paying out of pocket. I think not all senior refugees get to be accepted through the system, and we need to discuss this further. For Palestinian refugees from Syria, they rely on the UNRWA for medical coverage, but again, they have a lot of issues, as we would realize and we show in this research. For stateless, and most of the stateless whom we interviewed in this research were Bedouin communities who are Lebanese, but from Bedouin origin. They were excluded from governmental healthcare services, and they rely mostly on out-of-pocket, or sometimes they get supported by their community groups or their tribal connections. So what's the journey mapping? Journey mapping goes into the details, and this is the methodology we applied here. I mean, we could have opted to qualitative research, asking about the experience, but we opted for this quite interesting method, but also quite complex in its analysis. Perhaps that's why we had a lot of time to do the analysis. And the idea is to actually walk with the patient step by step through the journey of hospital care. From the moment they feel that they want to, they need hospital care, to the moment they leave the hospital, whether it's satisfactory or unsatisfactory. And usually this method is applied mostly in, places where there is an interaction with customers and businesses, and we tried to apply it here, and it was quite successful in highlighting some of the very interesting moments or touch points where those seeking healthcare or hospital care went through. And we actually tried to look into 3 of the main touch point or milestones. So this is kind of the journey. This is just a model, from the literature. And we wanted to look into before, during, and after the hospitalization. These were the main touch points where actually we want to see the experience of the refugees as well as the Lebanese whom we studied. And in addition to understanding the details of this journey, step by step, we also wanted to actually explore the 3 factors, or the connection or the impact of these 3 factors. Legality, whether they're legal as refugees or not, like registered or not, legal or documented, to use maybe a better term. Nationality between Lebanese, Palestinian, Syrian, and stateless. And speciality, where they live, rural, urban, camp, and non-camp. So these were kind of the factors we wanted to also understand whether they had some impact on the hospitalization journey. And we went to, this is qualitatively asking about the experience, really understanding the real life, story of those people who went through those hospital care. And this is kind of our sample. It's, of course, qualitative research, but we actually did 122 interviews from the different population. Of course, the smallest group were the stateless, because they are the, not so easy to capture, particularly in Beirut. But we also relied on this small number to understand their experience. And from 122 cases or households, actually, we interviewed, we captured 146 patient journey. So those were 146 cases where those households attempted to seek hospital care. Now we're going to see if they were successful in delivery and its actually, final outcome or not. And the most common cases were emergency services, of course, surgery related, birth, delivery, and other treatments. And we focused on 4 of the touch points that were identified through these interviews. The selection of the hospital, which is the initiation of the journey, the admission, how they entered, the treatment and coverage, and then the discharge when they left. And although we wanted first to focus on 3, but the initiation and the hospital selection appeared to be one of the touch points or the milestones in this journey. Now, out of the 146 journeys that we studied, 24 cases were aborted, so they discontinued care. Some of them at the beginning, others throughout in the journey. But this is interesting because when we analyze, and we'll show this later in more details, most of those aborted cases were patients from Syria, either Syrians or PRS. And that has some implications on the analysis later on. And of course, the reasons for discontinued journey were they refused coverage, they didn't get approval, they had long waiting times, and actually they did not apply for coverage and they left. Okay? And this is what we're designing at the moment. This is kind of the map in more details. This is, Jana has spent hours and days on this. And it's actually looking into the condition, how the entry into the hospital, types of hospitals, of course, and then those who continued, those who discontinued, why they discontinued, and those who continued, whether the journey was aborted or not, and when they ended, how they managed to do so. Of course, we're using quantitative numbers or numbers to quantify these, but this is, again, a qualitative research. So this is, again, for the Lebanese. We're doing it for each community. This is for the PRL, the PRS, Syrian refugees, and stateless. And of course, we're doing it for both communities, for those who live in Barilias and those who live in Sabra Shatila and around them. So when it comes to the Syrian refugees, we see actually those who discontinue the care are really quite high compared to those who enter to the care compared to other communities. And through this analysis, we're going now to understand the touch points, what's happening around those touch points and the main touch points that we mentioned. So when it comes to the Lebanese and rural Biqa, there's always a touch point around the process of getting the right papers for whether the Ministry of Public Health, the majority of them, or the NSSF, and there's need whether to pay a deposit or no. Again, this is not as major issue compared to other communities, but it's still one of the issues that's appearing in the interviews with the Lebanese and rural Biqa. When it comes to, again, to the end of it, There's an issue related to how to send the receipts, how to make the process work, and the co-payment, whether they have to pay and how much they have to pay and how to pay it. And when we asked about how to cope with the additional payment, I think most of them are relying on personal expenses. Maybe they're paying it from their own savings, but also they rely on assets or some of their friends and so on and so forth. When it comes to the Palestinian refugees who live in Biqa, it's quite similar to the Lebanese, by the way. I mean, there's a lot of similarity with the Lebanese. But again, the main issue that appeared several times, I mean, the color is red because that was the frequency of reporting this issue. It appeared mostly around how to pay for the additional amount, and mostly done through borrowing money or sometimes going to some of the charities to be supported to pay. And again, when we say 15%, for a poor family of a modest income, if this is more than $150 to $300, this is still a huge sum for such families, and sometimes it's much higher. When it comes to the Syrian refugees who live in Biqa, there's always an issue when it comes to preparing the right documents and whether they are actually following the process of approval through the UNHCR system or whatever is put in place in those hospitals. And this is key. And this has been one of the main issues that's actually affecting the Syrian refugees' journey into hospital care, and of course paying for the additional charges. Now, there's something we notice among the Syrian refugees, that actually the duration of care is really the shortest among all the others. It could be because of the cases, and we did not actually go into the details of it, but it also could be that the way the private hospitals are dealing with those refugees is trying to make the duration of care quite short to perhaps save some of the money, or because that's the agreement with the UNHCR. And I really need to qualify this, and that's the right forum to validate some of these findings. When it comes to how they cope with the additional funding, with the additional money that they need to pay, actually it goes to, they need to collect from neighbors, family. There's lammi, it means or we borrow money, and actually one of the issues they pay, the way they do it, and one of the rising issues that they pay from the money they get for the multi-purpose cash, or whether they have cash assistant, they go and pay it into the hospital care. Now, similarly, the PRS, Palestinian refugees from Syria, have very similar situation. Now, when it comes to the stateless Lebanese in Biqa, it's all out of pocket, and they have to pay large deposit in order to get the entry, because they're relying on out of pocket payment. So that's kind of briefly, I mean, very simply, we're visualizing it at the moment, but this is briefly the main, mapping of this. But when we went into more analysis or synthesis of these maps, we started actually with those who discontinued care or aborted care altogether. Lebanese, they are minority, really small number of them, but still they were not able to pay. Similarly, for the Palestinian refugees who live in Lebanon, did not get UNRWA referral. Again, they're small in number, by the way, but we want to explain the reasons for discontinuing care. But the majority of them, again, were Syrians and PRS. And the majority of those were unable to pay because they were refused admission by UNHCR contracted hospitals. So that's the main reason for aborting care and again, we're showing that perhaps not to quantify this, but around 40% of the Syrians whom we interviewed, they discontinued care. Similarly for the PRS, they're trying also to maneuver all the bureaucracy around whether they're allowed coverage through UNRWA or not. For stateless, they cannot afford it, they don't do it altogether. So that's kind of the first synthesis from these maps that we are visualizing at the moment. The second synthesis is related to how they pay, the payment methods, and again, we went and studied all the payment methods. For Lebanese, again, they're covered mostly through the Lebanese, coverage, whether NSSF or Ministry of Public Health. For PRL, again, they're mostly covered through the UNRWA. Now, for Syrians, this is interesting because less than half are covered through the UNHCR system. Out of pocket is huge, and NGOs 4. We actually had assumed early on when we designed the study that religious authorities would be paying some of this, and actually it did not appear as a significant contributor to the payments for Syrian refugees. PRS, again, UNRWA, but others are out of pocket, and for the stateless, out of pocket. And when we did more synthesis around how they co-pay, whether the method of co-payments, most of them were actually getting support from others. Almost all the refugee and stateless communities refer to borrowing money or debt. So there is, borrowing money, perhaps from mostly family members or neighbors and others. Now, religious organizations did not appear as main, but they did actually appear here and there. But you see family support and community support as the main support for all of the payment of these or co-payment. And this is interesting, in the literature of adaptive mechanisms and the way refugees or, poor communities adapt to hospital care or payment of these catastrophic expenditures. We see here a lot of, emphasis on the family and the community support, unlike what we thought that it could be more formal NGOs, formal charities, formal religious institutions, which is not really the case. In some cases, they go back to Syria for cheaper treatment, something Gibran Basir should not know about, but let's see here. And actually, they also get support through sometimes the network, particularly in the camps. But what's also something interesting in the coping with the co-payments, that in Syrian refugees, they pay from the money they get from the cash assistance that they get. So some of this cash assistance that they're receiving, whether as multi-purpose cash or other forms of cash, is being paid whenever needed for hospital care. So this is kind of an overview, really. We didn't go into to bore you with the details. The paper is long, it's maybe 15,000 words, but we're trying to summarize it with the details. But let me conclude from these factors that we try to look at. The legal status or documentation, is really key here to access hospital care. Part of the touch points, and particularly into the selection of hospital and where to go, has to do with having the right documents, not only through the process of admission, but also to select the right hospital. And sometimes they don't have the ability, particularly Syrian refugees, to move around because they don't have the documentation that they don't have the legal residency, it's not renewed, and so on and so forth. So this is a key issue when it comes to, access or selecting the right hospital for the right care. In addition, those who are stateless populations who have, they don't have the right documents, and that's related to, their legal status in the country, are also having issues with hospital care because they're not allowed any care. Now, so this is key. I think issues of legality of documentation are essential for any policy recommendations, and we would like to also discuss this further with you. The other point when it comes to the place, we assumed that rural versus urban might be some difference, and we didn't find any real difference between these two communities, and that's interesting. Only slight difference in the camp and non-camp communities who live in Biqa', we actually found some kind of support from those who live among Syrian refugee camps. I think it was Al-Audi, Sheikh, it was Al-Audi camp. And I think this camp is also under risk of demolition at the moment, sadly. But because the camp is kind of a close-knit community, particularly in this camp, we've seen some kind of crowdfunding, like people come to support each other in case of emergencies. Now, an interesting dimension or factor that we've realized, and we would like to conclude on and maybe discuss further, is the issue of, we call it longevity. Perhaps the UNRWA services are more established at the moment. Not perhaps, they are more established at the moment. They've been for years. I know UNRWA has been doing a lot of healthcare reform. The whole, the health component of UNRWA has been going through a lot of reform and update and research and so on. So we could actually assume the experience of the Palestinian refugees in Lebanon has been, smoother to the Syrian refugees in Lebanon because of having more institutional setup of UNRWA, particularly around the healthcare. But that's again for discussion. And we would like to discuss it further with our colleagues from UNRWA. It could be as well that Palestinians in Lebanon who have been, now this is the third generation of Palestinians in Lebanon, they also know how to maneuver their way. They know how to maneuver their way around which hospital. Sometimes, they move around the country. Perhaps the hospital in Saida is offering, services now compared to the Hilal Ahmar and Barilias. So the family goes in. There's more knowledge around what's happening. That has to do with their, social network, with their connectedness in society. And that perhaps can explain the journey for Palestinian refugees in Lebanon was, again, smoother than those for Syrians. But also we've established, although, with this small number of cases, the Syrians who've been living here since 2011 were better, had better way of maneuvering in these journeys of hospital care compared to those who came after 2015. That was quite interesting, again, as an indicator. So perhaps as people settle, they would know how to manage their access to hospital care and they can maneuver around it. There's an interesting dimension of the alternative treatments, particularly, for those who abort care or discontinue it halfway, and that has to do with, resorting to cheaper options like pharmacies. I think it happens across all communities, but it's more apparent here for those who abort care altogether, but also Arab medicine, informal doctors, some of the doctors who've been operating informally, and so on and so forth, including for a small number of them going back to Syria. And actually to conclude, I want to take this further into, showing that all communities have reported the high cost of hospitalization in Lebanon. The journey is not smooth for all of them, but it's been harder for others, particularly for Syrian refugees and the PRS and the stateless. And I think this is quite interesting to discuss further and to see how to develop processes that allows them better access and smoother access to hospital care. But I want to actually end by raising some question, perhaps for you to discuss, but we can also open it to any idea that you'd like to share or discuss in this forum. The first is how to mitigate those challenges and barriers that refugees and vulnerable communities face while seeking hospital care. Part of it has to do with the process itself, the right information, the right documents, making them smooth. It doesn't only have to do with funding, and the funding is key, but also the issue around access to this, starting the journey, what's needed to get into this journey. And the second question, how can processes be improved to ensure that care is, received when needed, particularly when we talk at the level of the government, aid agencies, insurance providers who are as subcontracted providers or third party, and as well as hospital level. And how to really work on enhancing the patients and the family and the community's agency, knowing that almost all of them rely on the support of the community and the family, and as a way to actually help them cope with the needs of health care or hospital care. I'll stop here and perhaps ask Jana if you'd like to comment, and Hala as well, if you have anything to comment.
I think most of you will have questions on access and methodology, so maybe I could talk more about that. The way that we did it, we thought that we didn't want to go in or barge into a community as like academics. So what we wanted to do is we wanted to establish connections with NGOs in both community and in both areas, Barelias and Shatila. So we partnered with two NGOs and like one NGO in each community, and we created a team of like 4 researchers in each community, in each area, And the good thing about this is that when we went into the interviews, it was really like the people were able to talk to them freely. And this is basically the good thing about our methodology or the journey mapping is it's not only capturing structures or it's not only like processes and all that, but it's also capturing their feelings and their emotions. And like some of these interviews went on for like 3 hours because they really felt like someone was talking to them. So I think like that's one good thing about the methodology that we used. And another thing is that it allowed us to compare across the communities and in different areas. So like the visuals that Nasser showed were like very primitive. Those were at like the early stages. And but when you put them like across each other, you can actually like identify the different like the difficult like touch points and like you can also like it's across emotions. Like you can actually feel like all these communities, they do all like face the same types of difficulties, but maybe some more than others. Like for example, I haven't been like into this for like more than a year now, but I do remember that one of the coping mechanisms for the Bedouin communities was that we couldn't actually find someone who had been to the hospital in the past like year before the interviews. And basically their major coping mechanism was that they decided not to go into a hospital anymore and that they would rely on like self-medication. So I mean, like when you actually compare rather than just like focus on one community, it doesn't show you like these. Yeah. Basically, that's it. I mean, we can leave it. I can answer more based on your questions, but I just wanted to add this thing.
Okay, great. So again, I mean, as Jana mentioned, this was a long study with, I think, one of the longest pieces of research we've been working on, and that's why it's taking a lot of time to finalize. But so we tried to make it simpler in terms of the graphics and some of these summaries. But again, we're open for any discussion points you'd like to add or validate or maybe contradict if you have some of these ones. And really, thanks for listening. No questions. Good. Let's have coffee break.
You mentioned the name of the NGOs that you collaborated with in Bar Ilyas and in Beirut.
I'll give them individually.
Okay.
Just for the sake of.
Because you took it from the perspective of the community, and what about the barriers that we have to access coming from the medical community in Lebanon? And I've been working for the past 4 years in a governmental hospital, and what we're struggling the most is this overprescription, over treatments that people cannot afford, that is not necessary, and then people, they would leave with their condition, knowing that they could have done something and paid for it if the system was more controlled. Is this part?
No. Not in this research, but we're working on another piece of research from the provider's perspective. So the point is, from the healthcare providers, they're overprescribing services or medication or tests or. Yeah.
Yes.
And that's creating more burden on the patients as well as the healthcare system. Yes, of course. But I think those who follow they're covered. They also work within what's allowed to be. But I don't know the details of this until we finish the next piece of research we're doing. It's a good point, yes.
Actually, the journey mapping method in other countries, more established and more developed countries, they actually is used by hospitals and like by medical service providers. So I think, I mean, I should take this on, but it's also like the responsibility of the medical care providers to actually do those like exercises to actually identify the needs of the like their beneficiaries. So I think like I would invite everyone here who is part of like a hospital or a medical service provider to like take this methodology on.
So I was seeing that you are referring very much for the PRS. The PRS, we received them and we treated them in the same way as PRS. So we have a huge net for Ottawa, and it wasn't only for health care, it also was a complete care for everything. So we had some focal points at the border, and we were receiving all PRS, and we were treating them the same as PRI. So I think that with all respect to your presentation, but there is something missed here. I know we were receiving all the PRS at our health net in all areas. We were getting them and we were providing them with all basic health, primary health services at all. Second, we were facing some problems, as you said, with the documentation, because usually they were not relying on UNRWA services at Syria. So here we were trying to help them how to update their documentation and then to provide them with all the services. What we did is that we received all the patients at all our health centers, because our health centers are able to receive were able to receive the amount of refugees that we received from Syria. Second, I don't know if everyone knows that we have the quantity of medication that at primary health care where we could provide the medication for all PRS. And second, we were treating them for hospitalization, referring them according to our hospitalization system. And our hospitalization system is divided at two levels. One is secondary and the other is tertiary. We divided like this because we wanted to control our budget. So at secondary health system, we were referring everyone with a coverage of 100%. Okay, for especially for the PRCS hospitals. Then we were providing them with 90% as we provide PRL with the same amount and same quantity of money to governmental hospitals and other secondary contracted hospitals. And the other 10%, we were able to gather them from other NGOs, especially Palestinian NGOs related to the embassy. So we had no problem with the financial coverage at secondary hospital. Then we had what we call the tertiary health, the tertiary coverage, where we have contracts with some hospitals that are costing a lot of money, and there we were also providing them with 90% because it was an emergency, and we had the money as honorable because we transferred the money from Syria to Lebanon. We had no problem with this, if you want, bureaucratic system of transferring money and accommodating patients at our health centers. But really what we faced is, as the lady here said, that there were abuse in the health Lebanese system. We were facing a lot of problems, many problems with treating physicians at hospitals because they were requesting so many lab and X-rays requisition, unjustified, if you want to say, and even in the delay of hospitalization and length of stay at hospitals, we were facing these problems, and also with the medication requested for the patient after discharge. And here there was a problem because we haven't all the medication at our health center. All the medication, if you want them, the commercial names, we hadn't all this at our health centers, so we were facing some problems there. But I want to say that UNRWA were providing the same quality and the same services for all PRL and PRS at the same time, and we had no discrimination. Even we were providing them the same services at the same health center, and sometimes, not sometimes, all the time, we were providing PRS with more financial assistance than PRL because we know that when they arrived to Lebanon, they had no work, and even the cash assistance that UNRWA was providing them is not enough to pay for hospitals. Our major problem was not the financial challenge, if you want to say, because there were other NGOs that were handling cooperation with us. We were doing the coordination to cover the 10% that the PRS couldn't pay at hospital, the co-payment. But our main problem was how to update the documentation of the PRS at Lebanon. And it was also not so difficult for us because it's in our registration system. Thank you.
I mean, we totally agree that the issue of PRS was knowing the process. They didn't know how the process works. I mean, not saying that UNRWA would not cover them. I think we all agree that they are within the formal system of coverage of UNRWA, but through their own views, they had issues around understanding this process. And they're coming from a different system, they didn't know how to adapt to it, and so on. So some of the recommendations, or maybe now, because this happened more than a year ago, so maybe you're working on it, and we need to update some of these formal processes, but it's to raise more awareness around the process itself, what's needed, the papers, how to go and where to go, and so on. Whereas Palestinians, PRL, using the terminology, know the system much better. That's our...
At the beginning, maybe, but
Yeah.
we started with a campaign, a honest campaign, and
Okay.
at all camps of BRCS, but till now we are still facing some questions, some queries from them that they think that we are providing different medication to PRL and PRS. They think that we are providing different services, especially at hospitalization for PRL and PRS, while we are providing PRS more than PRL, which is not...
So first, congratulations on the great work. I'm sure it took a lot of energy to do such interviews. It wasn't an easy one, I'm sure. Second, in response to the comment actually on the abuse of the medical system, this is actually something that's ongoing with all populations, so it's not limited to refugees. We've been observing a lot of malpractice or abuse of the system, whether it's in terms of demanding labs, the labs themselves, prescribing medication, the pharmacies. So it's a problem of the medical system and the health system level, which actually asks for a intervention from medical providers, but also from holding some sorts of guidelines. So we were part of the European Center for Disease Control guidelines for screening and treating migrants arriving to Europe, which was an effort that was supported by European teams and hospitals and governments, of course. But unfortunately, we did not see similar efforts in Lebanon or low-middle-income countries that were hosting Syrian refugees. So guidelines are similar to best practices outside health, and when we have guidelines, we can hold physicians accountable, but when we don't, then there's no accountability system. So something to think of.
So I was just wondering, actually, if in your research you felt that the coping mechanisms that came out are being saturated. I work at a community clinic near Shatina. We have many Syrians, many Lebanese, and also those without IDs. And I'm very glad and encouraged that this issue is getting light. It's almost impossible, as you said, for those patients to enter hospital. So it's good that this is becoming more of an issue because it's very dangerous actually at the federal level. But regarding the coping mechanisms, at the ground level, we feel that the ones that were mentioned are being saturated. It's very hard to get debt. It's very hard to get help from NGOs, etc. So I'm wondering if that came out and what your thinking is about that and what can be done. Also the issue, of child labor. And we see some people relying on children to work to cover medical debt. I don't know if that came out also at all.
No, it did not come out, the issue of child labor. Perhaps we did not, it didn't appear as the main. But you're right about these are getting saturated. I mean, when we did this like 18 months ago, things were perhaps different now, things changing every year. But I think they would still try to help each other. In another research we just concluded, we did a few months back, related to shelter, there's still reliance on family borrowing money. But yeah, you're right. It's getting more and more kind of strained at the moment. So one of the points we would like to discuss how to support those community groups. I don't know how, honestly, whether through cash, but cash cannot happen. Money is not getting less, but it's going to different sectors at the moment. Money for the response system. So how can we actually work with the grassroots groups, organizations at the level of community support? I think the tide is coming more and more against refugees. Support of them.
I could just offer, I think the issue is structural. I mean, why do we have this copay that's everybody recognizes is very heavy, whether for Syrians or for Lebanese? And also emergency room fees are very high. It's a big deterrent for people to go to the emergency room. So if we can enter at the structural level versus trying to subsidize at the grassroots, it's very challenging to know, and a lot of people fall through the cracks. It can be more at the macro level.
Sorry, did I miss? So can we have the question here and then we go?
Yes.
Please, thanks.
I'm wondering why you didn't do a more systemic approach. Because, I mean, when you present the result, it seems like the Lebanese situation is quite working, while for the other community is not. In reality, we know that even for vulnerable Lebanese, the situation is far from ideal, because I mean, the system of the Ministry of Public Health, like a last issue or last resort, is not efficient. In many cases, there are people that are rejected by the hospital, and then they have to have long queue and insistence. I mean, it's not working well, because in Lebanon, we miss a system in which everybody is insured. We have no universal healthcare coverage. This is the basis. So the Syrian crisis, it's an opportunity, in fact, to enter, with the money of the donors, to enter inside the Lebanese health system and to try to improve. And this, I think, should be the angle in which to observe the line. Because if we continue in a humanitarian way, this is not sustainable long term. Also, I mean, if we create a parallel system, we cannot have an impact in the Lebanese one. That is not working. So, I mean, why is that this research is not looked under a lenses in which you say, okay, the system is not working, so many vulnerable people that have a lot of difficulties, because even if at the end of the story, being Lebanese, you manage to find coverage, is not efficient, because it's that you have to ask to the family, sometimes the television, the newspaper have to come because a case is not covered. And then the Ministry of Public Health is also spending a great amount of money for these cases, because there is no preventive care, people go too late to the hospital, they didn't have access to the primary health care, so everything is very much interlinked. And I think that after 9 years of the crisis, we have to use the opportunity to see things in a more integrated way, in which the Ministry of Public Health and in general the health system in Lebanon should be reinforced, and the secondary as well, and the insurance for everyone. And then, I mean, we can think how the donors and the international community can cover exactly the same system, but for a refugee population. And I think that this is like the approach that we miss here, because otherwise, I don't know, if we continue like this, it's very expensive, it's not efficient, and it will continue. And also how to prevent the medicalization, because again, it's very much linked to what the colleague was saying before. I mean, there is our over-medicalization, but also because there is not enough primary health care, and the people arrive as a last resort often.
I think, I mean, this wasn't a study, again, it was from people's experience and their journey, so. And we're just reporting it based on analysis and synthesis. I agree with you that the healthcare system in Lebanon needs a lot of attention, but we have to be also realistic here, or fair, or you know, objective, to use the right term, that the Lebanese have better ways to access hospital care as a last resort compared to the others, particularly Syrians and stateless. And so I think, yes, it's not smooth. Yes, it's you know, bureaucratic and has to go through sometimes, you know, calling connections with some of the political figures or parties and so on. But at the end of the day, regardless if it's too expensive and it's not efficient. I totally agree with you, and this is not the objective of the research, but at least those Lebanese patients, as we saw in this study and other research, may get and would get some kind of hospital care. Now, when it comes to primary care, I fully agree with you. No, that's not the vision of the ministry. The ministry thinks that the primary care is working, but I think you're right. We need to work more on the prevention. And mostly, as Dr. Tamara mentioned, the issue of the cost of care and oversubscription and so on and overprescription is becoming key in the healthcare system in Lebanon. That's quite costly, relies a lot on out-of-pocket for everyone, and so on. So you're right. But based on this research, I think we've realized that the Lebanese are slightly better off than the other communities. Please, Anja.
So I wanted to say just one thing in response. When we were doing the literature review, it actually showed that I don't come from a public health background, but I mean, I found that out when I did the literature review, is that most of the research in Lebanon on the healthcare issues, they're actually more systematic, at the systematic level. You may correct me if I'm wrong, but this is what I found out. And actually, the beneficial thing about the methodology that we use, it's not just at the individual level, but through talking to these people, they actually also mentioned systematic issues, structural issues, issues at the primary healthcare level, like the referral process. And I don't, the presentation didn't show that, but when you actually, because you didn't get to look at the visuals and all that, but you actually see those things, at a deeper level. So I think that what the methodology we used allows us to capture the hospital, even at the hospital care level. Some of the interviewees mentioned how badly they were treated by ER, people at the ER level. These are things that are not usually shown, at least from what I had to go through from the research. So I think you just have to wait and read the report.
The issues of the structural level around healthcare are for another piece of research. And I think there's a lot of work happening on the cost of care, financing it, and so.
I would like to add, this is a qualitative study, so we cannot generalize from this. We took a sample from different camps or not camps or from different area in Lebanon. So it's just kind of touching point on what's happening and getting the perspective. I do agree that, and this is the forum where we're here, we're just trying to tell what we get from our study, and this is the point of view of people. So I know you might disagree, but we're just trying to communicate what we were able to do through the qualitative work. So, and we're here to listen and to get clarification like you just did and explain. So please just keep that in mind. It's qualitative and there's a back and forth and communication to this work.
Yes, please, and then.
Thank you. First of all, thank you so much. I'm Jacob, I'm a public health officer in UNHCR, so I'm very much involved in the refer care program. So it's very, very interesting. Very grateful that.
I know you updated your system, I think you month back, so
Well, it was a year back we updated, but I think so. This survey was done before a lot of the things that were mentioned is things that we have been aware of and trying to address, but with various success. Some of it was a bit surprising, especially one thing I wanted to just, if you could clarify, that there were so much out-of-pocket expense that people actually did not get any support from UNHCR. And I wonder, was that choice or lack of knowledge or that they were refused? Did you go deeper into?
I think the out-of-pocket includes those who aborted care or they refused care. They don't continue care, so they relied on the out-of-pocket, and the out-of-pocket was also to, mostly to also be supported from family members or people around them.
Because one thing that we are often concerned about is how much is actually reaching the refugee community, or the information that we are trying to get out there. And it's often surprisingly, you get surprised to see that the quite still a lot of refugees that are not aware of the support system that UNHCR is. So if any of that, if some of the people that you interviewed was actually aware or not aware of the...
And actually, some also were not registered with UNHCR. I mean, that's another thing.
Yeah.
Some of those
Yes,
interviewed were not part of.
Different topic. So I just wanted to comment also a couple of things that might give or put some of the findings or give some explanation. So I mean, so someone here was mentioning that why are we still with the patient share and out of pocket when it's such a burden and hurt? I mean, when it all comes down to it, it's about funds, and I mean, it's not the model that UNHCR or the program that has been put in place, and I'm sure it's the same thing with as well. That I mean, it's not like we believe that this is the absolute best solution in order to guarantee access to everyone. It's a very delicate balance with trying to use the funds available and that making them to come to the best use as possible, knowing that it's limited. So one thing that was not mentioned here in the introduction of the different system is that not only is this a patient share or cost sharing system, but it's also a quite detailed guideline for certain conditions are not covered. So, diseases or chronic conditions needs long-term treatment, several admissions is not covered. You have, it's also things that are not urgent or urgent life-threatening is not covered. So a lot of the answers, I think, when it's being said I was denied care or it was not covered, might be because they were not fitting the criteria that has been set up. And again, those criteria are not there because of our fund. I mean, it's because it's you have to use the available funds in the most efficient way possible. Yeah, I mean, also the funds. It's the fact that there are the number of Syrian refugees are there are so many. So it's also I mean, I think for UNHCR, this is one of the, if not the most expensive hospital care programs that in any of the refugee situations.
I think that's a good point not to say that otherwise only doing a good job because they've been established and they know the system. Also, the numbers are much less. Yeah. I mean, I don't know if the 175,000 is a real figure or not, 175,000, but the numbers are much less compared to the number of population that UNHCR also is serving.
But if you compare the number of PRS with number of PRS, lately, I think, in the consciousness we had 174 PRL.
Yeah.
And at one time, at a certain limit, we had 100,000 PRS.
Yeah.
Yes.
For us, it's a big number.
Yes.
And I also wanted to comment, it was mentioned several times, the abuses within the system and unnecessary prescriptions and so on. I mean, that's another obstacle when it comes to establishing these programs, because you need to put mechanisms in place to control care, that there is not unnecessary investigations done, that interventions are really done for a reason, etc., etc. But that also, for every mechanism you put in place to control, that makes it more difficult for the person that seeks healthcare. And I mean, that's not from their perspective, it's just the pain, having to deliver the ultrasounds and lab results and proof of this and proof of that, and it has to be provided, otherwise no coverage. That would also be fantastic if you could reduce those mechanisms, but it's difficult when you're dealing with a system where it's built on fee-for-service. There are so many rigid incentive structures here that is, makes everybody or the healthcare, the provider side, to do a lot of unnecessary things, which from the funding side we need to try to control. But yeah, once again, I think a very interesting study, and I'm looking forward to actually read it. So when is it already out?
No, in a couple of weeks.
Okay.
We wanted this session of this meeting or seminar to also validate some of our findings and update them if they make sense. Because again, we did this 18 months ago, and we just managed to finalize it this week. Take a question, and then back.
So thank you for the study. It's a little bit in line what was just said. So the type of admission you focused on, I was wondering it was acute condition or cold cases. So I don't know if you captured that or not.
Captured the conditions. Yeah. I think they were. We mentioned some of them were emergency related.
Yeah, we followed the journeys according to what type of أي مرض or أي حالة يعني. Then based on that.
حالة طارئة أو حالة باردة.
مثلا ER كانوا مع بعض، كل حالات الكرونيك كانوا كمان مع بعض. يعني it was dependent on.
Good.
We did them. They are on. They will be in the paper anyway.
Because it didn't show here.
For example, so ER, there's surgery, delivery, medical, so we know we've also.
Yeah, but urgency doesn't mean necessarily ER, because can be directly admitted to the hospital without passing through the ER, and it's an emergency. So it's not necessarily the ER. And we can go to the ER as primary care service, not as ER.
But there's tendency. I don't know if it's a tendency, but that also happens among the Lebanese population. People go through the ER. So they go.
Sometimes they go as primary care, not as because they don't want to, because it's evening. They don't want to wait to the morning.
There's also going through the ER and then continuing into the hospital.
My second point was about the Lebanese, because I don't know also if it was linked to the when they get their admission at the start of the month or end of the month or end of the year. Because the funding, the availability of fund at MOPH differs a lot between these periodicity. I don't know if you looked also at that. So this is my second point. My third point was about more the scope of the study. So it was more about people who initiated hospitalization, because a lot of them even do not initiate. There is indication and they don't initiate. So I don't think it was in the scope of the study, right?
Just asked about people who are really got into this journey, initiated this journey, and some of them discontinued, others continued.
And I had also a question about also so it was more mapping what is happening, but not if the care will continue or not. So, for example, at discharge, so they were sent, were prescribed medications, if they will be able to pay for this medication or not. Was that included?
We asked about the discharge, about the co-payment, but not necessarily about the details of the medical care after. We did not go into the details of.
And how to do that? Okay, the linkages with the.
But whether it's satisfactory, not how they managed to pay or not, What was, the outcome of this?
Because
Not the medical dimension of it.
yeah, so why I'm pointing on that, because I agree with completely with the opinion about saying though that we need to reinforce primary care, because when we reinforce a lot of primary care, then we'll decrease hospitalization and we can do more with the same amount of money. So this is why linkages with primary care and how they, on what type of medication they are prescribed, if it is within the essential list of medication or not, is very essential about the continuity of care. Thank you.
Very good point. And I think Jana mentioned it when it comes to the referral.
Actually, we did ask many of them, like, شو بتعملوا بعد ما عطوكم what do you do after? And many of them were like, okay, they gave us a list of what we should get and all that, but no, it's too expensive for them, for example. So a lot of this was mentioned, and a lot of them did actually mention primary care as like an important issue.
Yeah. So just also to note that in the new accreditation standards for hospital, there is a standard on that. So to link vulnerable population to primary care, national primary care system. So.
Why they are refusing to be referred? In depth. Why they refuse this?
Why they refuse?
Yes, which type of care that they refuse to continue accessing or going to the hospital? This one.
I think we have the reasons for refusal in the paper.
It's important for us to be sure to see why they are not continuing care and seeing hospital.
And opting out was not just at the very beginning, so because many of them might start then opt out at different times. So you will see from the paper that there's at different stages. They might start, then they decide to stop for different reasons, and we will be mentioning those.
And we heard also for the challenges of prescription, and they also have the hypothesis and medical supply, high cost and expensive, and this is sometimes people or refugee will choose to stop or to not do the operation.
Please.
Yeah, I would like to thank you so much for the study. It's very interesting, the whole mapping, the different milestones that the patient goes through, and also using the Lebanese as control group. So this is very nice. However, you said that the Lebanese were slightly better off than the other categories.
This is the process.
But you didn't mention how they were better off. Especially, we know that our medical system has been through a lot of austerities, budget cuts, and we know that primary or public hospitals are not even thinking of or thought of when we seek any kind of care. We usually go to private clinics. And I would like to second the lady that she mentioned how we want to, I know that it's a qualitative study, but we also need to integrate the macro health national systems. We need to, to mention this kind of structure, because migrant health is more of a magnifier into like deep structured inequalities that we face, the corrupt system that we have. And we usually have this kind of statement of people are refugees came to we always have this kind of broad statements. I'm blaming refugees, not blaming the system. My second point about the aborted journey, and you didn't mention this kind of the consequences of aborted journey, like the pain, what we go through with the aborted journey, and your recommendation. Like your policy recommendation, what to go through to help in resolving this kind of impasse. And I would also like to add another point about differentiating the different level of care, primary, secondary, and tertiary. And to what extent, I'm not really familiar with the Lebanese health system, but I would like to know about the primary health care and whether it's like a gateway to another secondary and tertiary level or not.
you. These are great points. I mean, some of them we can answer, others we'll definitely consider when we're finalizing the paper. I think, you know, we all agree that the healthcare system, and this will be included in the paper in the introduction, but also later when we synthesize everything together, it's a fragmented system, it's costly, it relies a lot on out-of-pocket, and there's a predominance of the private healthcare providers into the system. So I think, you know, that's something we need always to highlight. We're not saying that the Lebanese healthcare system is working, you know, efficiently and properly, but we're saying with these 124 journeys that we analyzed, those that the Lebanese households actually told us about were slightly better off in terms of the process, the entry, the journey itself, the interaction with the provider, and the outcome of it, compared to all the others. It has to do that, yeah, there are difficulties. We're not saying it's a efficiently, effectively, operating system, but we're saying that compared to the others, I think they are slightly better off in terms, at least, of the journey itself. Now, the primary care in Lebanon is mostly through non-governmental healthcare health centers, primary healthcare centers that are operated by NGOs, and through a network that the Ministry of Health has created to support them, not financially, but through non-monetary, medication, equipment, and they become part of this network. I think this is the biggest ones are part of this network, and it's expanding. And they get support also from donors and other, funding parties. But also there are smaller healthcare centers that are operating in the country. Since, the civil war in Lebanon, those healthcare centers or dispensaries emerged and they provide care at the community level. But it's not a system where it's so integrated that you move from the primary care to the hospital care or to secondary care when you rely or you need some kind of diagnosis. Or it's not a system that operates in a referral way smoothly as one would imagine the healthcare system is operating. I think it's a good point to highlight here, although we did not go a lot into the referral, but the referral issue is always key in the entry into the hospital journey. Take more questions, and then please.
First one, it's interesting to see in the research that there are some refugees who return back to Syria to get the services. The main point for why they return back to Syria, what type of medical services push these refugees to return back to Syria, and they stay in Syria to get the services or return back to Lebanon. I think it's not easy for a refugee who comes to Lebanon searching for protection to return back to Syria to get a services if not these services is much important and they cannot access here in Lebanon. The second point is about the sharing of information and the clothing of information. Sometimes it's so important accessing health services. And we see this in the research about first is the process of referral or the lack of documentation or the lack of information regarding documentation. And the other one is related to they get refused from the services and sometimes from the UNHCR. But they have information why they get refused. So sometimes they go to the hospital to get the service from the UNHCR, but they don't have information why you are refused from the UNHCR system. So I think sharing information, and not only sharing information, what type of information we should provide refugees with. And this information are accessible to refugees, clear and simple to understand and to read. It's so important and it's part of accountability in the health system.
I think, again, the small number of them are returning to Syria. But we put this as one of the mechanisms they do. Not to generalize. We're conscious about this, and I think in the paper we highlighted really small number of them. And I think they're mostly chronic cases, cancer cases, when they rely on the need. And I think that's always an issue with cancer patients, with Syrians. But you're absolutely right about information sharing and knowledge of what's in and what's out, and what's allowed in to be covered and not. I think things our colleague from UNHCR mentioned, you're right about this, and actually that's one of the recommendations across all the communities, is to have, even among the Lebanese communities, They have issues around, what's the documents that are needed and how to access them and from where. So you're right about that. Sometimes these small measures would make the journey smoother, at least, not necessarily. We're not actually forgetting the issues around the healthcare system in Lebanon, but sometimes these informations and sharing them would make the journey at least smoother for.
So thank you so much for this study and presentation also. There is one point that I would like to highlight, and this is the existing coordination mechanism. So at the sector level and under the Lebanon Crisis Response Plan, we try to ensure that all vulnerable PRS, PRL, and Syrian refugees have the same level of access to quality healthcare and hospital care as well. And at this point, of course, we know that the main challenge remains the lack of financial resources. And the one thing that we do here is that we do coordinate the activities among partners, and we do inform the program designs of several health partners based on existing gaps. So one example of this is, for example, the partners that would like to support secondary health care. There is a number of partners, health partners in Lebanon supporting secondary health care by supporting the co-payment, or what we call the patient share. I was wondering why it was not mentioned in when the refugees were mentioning how they are covering their co-payment. This is a very important component of the sector and the strategy. There is a number of secondary. So there is a number of partners covering as a co-payment. Of course, I mean, and this is limited to the existing financial resources.
Secondary care is always the most challenging for my students to understand, because people define it differently. So how are you defining secondary care in this?
Hospital care. Hospital care. No, sorry, it's hospital care. No, we call it, because for us at the sector level, hospital care is secondary and tertiary. Okay, so secondary is also hospital care. So this is one example of how at the sector level we do try to coordinate all activities, and we advise on program design based on existing gaps. I don't know, I was wondering why the patient share, for example, was not mentioned, and this is one question. The patient share are covered by the partners, and
by the partners,
yes. And the second note is, of course, I wanted to highlight the existing coordination mechanism working to ensure the same level of quality care to all refugees, based, of course, on using efficiently the existing resources.
They could only say, probably, I don't know, honestly, maybe those communities don't have such partners, I'm not sure. Maybe they do.
No, these are national partners, but of course it might be.
Sometimes maybe they say other support, maybe they mention as.
It might be also related, I guess, to the understanding of refugees. Maybe they mix sometimes the support from NGOs to the UNHCR support, something like this. But I wanted to highlight it. I thought it's important to highlight
This will definitely be updated based on last year's update from the healthcare coverage to include in the formal description of how coverage happens, and then we will rely on whatever patients told us about their journey and the analysis.
Just a quick comment on that. It could also be that it's the sample is not very large. I mean, it's when NGOs are actually stepping in and paying part of the patient share. I mean, it's quite rare. So I mean, in the big scope of things, so it might be that it was very few in this sample of 120 that you actually have.
Okay, very good. Do we have more questions? One more, please. Or two.
Thank you for sharing your findings and the opportunity to discuss. I'm Karim from NASA. So I'm interested to ask about the stateless people who were interviewed. This group include non-registered Syrian refugees. I'm also wondering about migrant workers, if they were part of the targeted communities.
We did not include migrant workers. We actually in the initial design we wanted, but it wasn't easy to capture. But for the stateless, as Jana mentioned, you know, the way the research was, we did it, we asked first if they had, they were seeking hospital care. So actually many of them said no, 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 we like it. So we only took 6 of them who said yes, we started, and that's how the outcome was. So for the stateless communities, mostly Bedouin community in Bihar, I think they are the worst off when it comes to support for any kind of hospital care, whether coping or any form of care. I did research before the Syria crisis on Bedouin community and the access to hospital care, and a good percent of them were relying on going to Syria at that time. That's before 2011, which is not at the moment something they can easily do. So they're relying on, you know, either going to primary care, you know, or their own way of finding, until it becomes aggravated, they go to hospital care and it comes out.
Okay, another point is more a comment actually than a question, but for the next step, concerning enhancing the patient's agency to navigate the system, I'm wondering if it would be interesting to look more at the role of social workers in helping with that, knowing that we often have difficulties ourselves keeping up with the updated mapping and change of projects and funding, just for the future.
Very good point.
Thank you.
By the way, the community volunteers, they do this awareness raising about the information, or they have this. That's a good point. Okay, more questions? Please.
Also on the stateless, I was wondering, did you find any cases where they were getting their care covered by NGOs, or were they only relying on family and friends far away from you?
The stateless. I think we didn't find, there's a small number, of course, it's not a trend of sample, but we didn't see anyone saying they're relying on NGOs for the stateless. But particularly the community we attribute to Bihar. So that was maybe in other places they would rely perhaps on Travelers or others. But for those communities we could not find anything similar. Very good.
Can I just make a small comment? Especially, I think in the first slides of the presentation, the word empathy was used, and there was a reference to really long interviews. Especially, you mentioned that the context has changed, and the study will be released in yet another wave of context change, namely increase in xenophobia and all of structural issues, racism, all of this. I think it's really interesting that the strength of the study, which is a small sample that is qualitative, also maybe a weakness of the study, could be published because it could help in advocacy. You mentioned that the interviews were long and yeah. Just jumping on the word empathy because that's a key one.
I think the study is not it includes these journey mapping, but also it includes thematic analysis of what the patient themselves mentioned around these touching points. The initiation until the discharge. And I'm actually doing now a second part with a former student colleague now from the experience that was her master's research, experience of the providers. And that's another interesting finding, hopefully we'll present towards the end of But actually, I think we can close now. I want to say something off, maybe not from this research, but from the research we're doing at the moment, which we actually realized while we're doing the analysis. There's a lot of patronizing behavior from providers to refugee. I think that's key. That's pushed me to do the other piece of research with Wala. There is patronizing, sometimes even condescending behavior and attitudes from the providers towards particular refugees. And that's something we're trying to work now on this another piece of research to understand how actually the providers perceive and view refugees when they provide care to them. That's also something did not emerge a lot in this because that was the patients did mention it, but actually we need to do more research to understand those dynamics. And Syrian refugees and other refugee communities mentioned the way some of the providers treat them in a negative way. So that's perhaps needs a lot of work on in terms of advocacy.
Thank you for mentioning this because it's something that I was thinking in the, we mentioned about the short admission times for the Syrian refugees.
Yes.
And here you really have two mechanisms that work together. So you have the hospitals, that the healthcare providers, that of course they it's good for them to have more patients, a faster rotation, and more paying customers. But you also have a not an insignificant part of refugees that prefer to leave the hospital. So, I mean, the majority of our admissions are due to deliveries. Yes. And there is a clear, I mean, it's not only something that hospitals come up with. This is quite often among refugees that they prefer to, as soon as the delivery is over, to leave and get home to the family and so on. But when these two mechanisms act together, where the hospital is saying, yeah, but these refugees, they don't want to stay. And then they actually push out even the ones that, you know, would need to stay, and it's, yeah, but you Syrians, you just, and also in the explanations when we are trying to push and ask, why are the refugees not getting the care that they is stated in national protocols, etc. Should be it should not be 8 hours for delivery. It should be at least to the next day or longer. And you always say, yeah, but that is the refugees want it to be this way. So what can we do? And then so the healthcare providers and their attitude towards refugees, and also how that it's linked to their financial interests, it's would be very welcome.
Okay, thank you so much. I think it's been a long journey for us to do this. I know we've been busy in many other things, but also the analysis has taken a lot of time. So really, we really appreciate your comments and the feedback that you gave us today. And we'll be publishing it hopefully in the next few weeks out as a working paper and then as an academic paper. We might also publish a summary of it because it's a long paper for policy and practitioners and policymakers. So great, we have a small break. We can have coffee and.
Thank you.
Thank you. Thank you.